you know that in 2021 a study was conducted that concluded 11% of people in South Africa live with diabetes mellitus, and that translates to about 4 million people. That is quite a lot. As you can imagine, diabetes sometimes can be misunderstood or even mismanaged, and this leads to complications such as kidney problems, what you call nephropathy, or peripheral neuropathy, and sometimes glaucoma, eye problems. But what about this one in particular? Diabetic ketoacidosis. Hi, you are watching ED Files, and I am Dr. Thabo Mafa. A teenage girl is brought into the emergency unit. She is accompanied by her parents, and her name is Miriam. The problem with Miriam is, before any history was given to me, I noted that she's got what we call Kussmaul's breathing. And she was lean. She was quite thin, if I may put it that way. Miriam looked very sick before the parents could even tell me what the problem is. The history given was that she was vomiting quite a lot at home, and they were concerned that she has not been picking weight for many years now. And sometimes even her classmates at school would make jokes about her, and they would call her lazy because she is sometimes lethargic, not having a lot of energy. And the teachers would often send her back home from school because of that. That has, to some extent, had an impact on her lessons in class. Now, let's break it down. What is diabetes? This is a metabolic disease that has got an impact on your sugar control and also your lipid control. The patient in most cases would complain of thirst, drinking lots of water, and passing a lot of water out quite a bit, I mean urination. And there's what we call polyphagia, whereby they eat quite a lot but not gaining weight. Instead, the opposite happens. They lose a lot of weight. There's two types of diabetes commonly that we talk about. It's type 1 diabetes and there's type 2 diabetes. How do we know which one Miriam is suffering from? Type 1 diabetes in most cases would occur in teenage years and up until the ages of 21, 22. That's when we discover that the patient is diabetic. But the most unfortunate part of it is that the time it presents itself initially, it presents itself as a DKA, what you call diabetic ketoacidosis, in most cases, but not all the cases. This is what happens. Your pancreas produces what you call insulin. And the pancreas has got a portion of it, what you call the islets of Langerhans. This portion of the pancreas has got beta cells. Now, this is supposed to produce enough insulin for sugar control. But in cases of diabetes 1, there is an autoimmune disease that takes place. And this autoimmune disease destroys the beta cells, such that there is no enough insulin produced from it. That would result in abnormal metabolism of sugar, and even the storage of sugar in your body becomes highly abnormal. So you find that the sugar levels in your blood are very high, but the very same sugar that is supposed to be used by your muscles and your cells for daily functions is not accessible to them. And the other reason why we see this type 1 diabetes in teenage years in most cases is that during that period, as the kids grow, there is quite significant hormonal changes that are taking place. So the growth hormone, the cortisol, testosterone, estrogen, as they start going up, they promote insulin resistance on those cells and muscles. And the liver itself eventually cannot store sugar for energy purposes. This is the reason why we see it commonly in teenage years and up until 21 years, 22 years, 23 years, around that time frame. The patient usually comes in with what we call Kussmaul's breathing when they are having diabetic ketoacidosis. Kussmaul's breathing is characterized by it's some kind of hyperventilation that you would see in a patient with acidosis. Your body starts forming a lot of acid and you get sick from it. So imagine in a fluid medium, like whereby there's blood, there's cells and other things in it, you need to have a balance of the acid and the base so that your blood is not too acidic or it's not too alkaline. There has to be a balance. Otherwise, the patient can get sick from that. What about the other one? Diabetes type 2. This one, the most important thing about it is there is insulin resistance. Your pancreas can be producing enough insulin from it, but your cells and the muscles are not sensitive enough to be able to absorb the sugar for energy purposes. And the risk factors associated with that is obesity, the diet that we eat, and sometimes, not involving ourselves in activities such as exercises. So now, how do we manage Miriam's condition? She is lying there with altered level of consciousness, vomiting, having abdominal pains, and looking very dehydrated. We need a few things to be able to manage this condition. We have to first check her sugar levels. On a blood gas that we took, her sugar levels were very high, unrecordably high, meaning that it's way above 30. We have to check also the acidity in her blood. If the pH is very low, like let's say 6, and her carbon dioxide is also low, we'll know that this patient is in metabolic acidosis. You also look at the bicarbonate and also the base excess. Her potassium was very high, it was about 7. And together with that, we took a urine sample to check for the ketones. There were 3+ ketones, there was 3+ glucose, but there were no leukocytes, there were no signs of infection in the urine. So we proceeded. We put up a drip for her. But what kind of a drip are you able to put in this case? You can choose to put a peripheral line, which is a normal drip that you see in a normal setting in hospital. Or you can go for what you call a central venous line, what you call a CVP. The advantages of using a CVP are that it's got a bigger lumen, so you can pump enough fluid at the same time. And secondly, you can monitor the pressures that you are creating within the patient, within the central venous system. So your central venous pressure should range about 8 to 12 centimeters of water. If it goes way above that, it means that you are more likely to overload the patient with fluid. Together with that, do not forget to put in a urinary catheter to monitor the urine output. Whatever fluid you are putting in, you should match it against whatever is coming out. Otherwise, there will be accumulation of fluid, and that can be deadly. However, if pulmonary edema occurs from fluid overload, give the patient Lasix 80 milligrams IV stat, and that could solve the problem. Secondly, what we do is we give them insulin. Some hospitals would give them Atrapid, and others would say it's Novorapid. Depending which one you are using, it's still okay. The insulin will bring down your sugars, and at the same time it will reduce the metabolic acidosis you have in this picture. Together with that, reducing the ketones that you see in the urine. Give them 10 units of Novorapid, which could later on be followed by an infusion of insulin. An infusion, if you want to give an infusion of insulin, just give them about 0.5 units to 1 unit per hour, running continuously. When you infuse insulin, you should also make sure that you don't run into trouble with hypoglycemia, meaning that low sugar levels. If your sugar goes below 15, then you need to introduce another sugar to balance things out. Give them half dextrose, or what we call 5% dextrose, to help the patient not to go into hypoglycemia as you are continuing to give them the insulin. You should also continue monitoring the blood gases to make sure that the acidity in the blood is improving. Together with that, keep on monitoring the ketones. We are going to have to give that insulin until the ketonuria resolves and the clinical condition of the patient also resolves. However, if there is no improvement in the acidity that you see on the blood gas, give them sodium bicarbonate. That's 8.5% of that. Give them 50 mils to 100 mils. And if there is a need to repeat that dose, you can do that again. Keep auscultating the patient's chest. Keep monitoring their level of consciousness. And keep monitoring for the overall clinical improvement. And at the end of the day, Miriam showed significant signs of improvement. In conclusion, diabetes mellitus can result in various complications, including diabetic ketoacidosis. I remember when I was still a student, our lecturers used to say that no patient is supposed to die from diabetic ketoacidosis. And having learned from that, I still believe that that's the way it's supposed to be. No patient has to lose their lives because of diabetic ketoacidosis. I think we need to take it upon ourselves as medical doctors, healthcare professionals, and even the patients themselves, to make sure that the conditions are optimally managed. So in conclusion, diabetic ketoacidosis can be fatal. If it's not been well taken care of, a patient can easily lose their lives. We have to make sure that there is early recognition of the signs and symptoms, and treatment is commenced as soon as possible. That's the only way we can be able to save the patient's life. So what advice can we give to Miriam? She has to be started on insulin as soon as possible. And she needs to understand that that will be her chronic medication. Secondly, she needs to be referred to a dietitian who will explain to her what kind of food she needs to avoid or which one she needs to stick to. She needs to learn to adhere to those instructions. Thirdly, she needs to avoid what we call steroids. It happens sometimes when someone has got, certain kind of illnesses, like tonsillitis or any kind of illness sometimes, or joint pains. One would choose to take pain medication and take a bit of prednisone. But in the case of a diabetic, we do not advise anyone to use steroids for whatever reason. Because steroids, like the hormones that we spoke about, the testosterone, estrogen, and the growth hormones, they promote insulin resistance, and the patient will have high sugar levels that are absolutely uncontrolled. And lastly, whenever a patient experiences any signs suggestive of infection, it could be flu-like symptoms, it could be tonsillitis, it could be urinary tract infection, they need to be on treatment as soon as possible. Diabetes mellitus, diabetic ketoacidosis can be treated, and there is good prognosis if it has been treated correctly. And thank you for watching.